virtually because we got feedback from trainees, particularly that were interested in applying for HPB fellowships, about just not really being familiar with the process and not really understanding exactly what was expected of them. And so we wanted to have and create some content within the meeting that was very focused on medical students, trainees, and at all levels, residents, including fellows. So we're excited that you're here. I think many of you have taken advantage of some of the other resources that we've provided. We have headshots, I think, throughout the day. Some of you guys have been able to do that. The goal here is to just give you an overview of the various paths into HPB practice and the fellowship pathways that are available for you guys to train. What is required throughout the application process, and then key aspects of the application and interview that I think most programs will focus on. And then at the end, we'll give you a chance to meet with a lot of the experts in the room who are program directors, division chiefs, people who have been practicing the in the HPB field for some time, so that you can ask them questions that may be a little bit more personal, and then they'll be able to go over that with you in detail. Some of you submitted your CVs ahead of time, and if you did so, then that individual will be able to meet with you and go over your CV in a little bit more detail. But if not, you can still meet with them. If you have a copy of your CV, feel free to hand it to them. Otherwise, you can just ask them whatever questions you'd like. So we're going to get into the didactic portion of the CV clinic with just an overview. The goal here is I don't want you guys to leave with any questions. So feel free to ask us as many questions as you want. This is a very safe space, and everything that you say here will be confidential for the most part. And then again, if there's other things that you find offline that we didn't address, just feel free to reach out to me by email and we'll get those taken care of. After we do the didactic portion, there are going to be some signage in the back that has the small group assignments and the one-on-one assignments. So we'll have a quick bio break. You can check the list, figure out who you're meeting with, and then we'll let you know where they are. Okay? So it really is a pleasure of mine to introduce Dr. Stephen Gray. He's actually a personal friend of mine, a little anecdotal story because I know all these people. This will be fun. So I met Stephen when he was a third-year resident at UAB. And I was applying to general surgery residency, and immediately actually connected. And he was, I think, a source of information for me during the interview. But even after that, I didn't go to UAB actually, but we stayed in touch afterwards. And he's just continually been somebody that I go to for advice. He's a transplant surgeon, currently practicing at George Washington University. And he's going to talk with us a little bit about getting into HPB career through the transplant fellowship pathway. Thanks, Stephen.
Thank you, Dr. Clark. So transplant is the obvious choice if you want to do HB surgery. I mean, if you go first, they don't have control of your slides. So, so you want to be an HB surgeon. Obviously, I've started brainwashing my oldest from birth. So kind of the pathway to HB through transplant is a little bit different. So ASTS is currently undergoing a process towards a certificate. There's actually now an exam that you can take at the end, but it's done through the ASTS, the Transplant Accreditation and Certification Council, which accredits the abdominal transplant surgery fellowship training programs. The transplant program is 24 months. And then the abdominal transplant surgery match is administered through the SF match. And the reason for that was changing from the traditional match to the SF match was kind of multifactorial, but some of it was to give us a little bit more leeway in the match process. I was the director of the transplant fellowship at UAB and then at University of Maryland. We don't have one at GW, so I don't know how the match is actually, I know how it functions, but not how it's actually going now. You apply during your fourth year for fellowship. So the key, I think, with ASTS or with the transplant fellowship pathways, you got to look. Not all transplant fellowships are the same. They're not all created equal. So there's the basic training fellowship, which is just for liver and kidney. And then you can have a specialized training or STF for hepatobiliary, hepatopancreaticobiliary, the intestine, and then pancreas. So not everybody who comes out of transplant fellowship does those additional organs, but those training pathways can only occur within an accredited basic training fellowship. And this is our pictures. The guy who's a year ahead of me in fellowship, and then Dr. Anchetta, who's actually here. He's a fellow. He was one of our fellows. I was doing a donor down at UK and ran into them on a Sunday morning. So the candidates in training in an accredited fellowship, they must have satisfactorily completed a residency that's accredited by the ABS or the American Board of Urology or the foreign equivalent. And then the training programs, each training program may have additional kind of requirements that they have. That's why I say with the transplant fellowships, that the key is to get on to identify the places through the ASTS website that train for the organs that you want. And then you need to kind of Google get on their actual site and look. Like for me, for example, it's funny, I was asking one of my senior partner who used to run who had the transplant fellowship at Georgetown, I'm like trying to figure out why didn't I apply to fellowship there? And then I remembered that they did intestine and I had no interest in intestine from when I was going through the process. So those additional things beyond the liver and the kidney, you need to look and see what your fellowship program is accredited to do. This didn't project as well as I thought it would, but this is kind of the volume requirements for a transplant program. I'll tell you that I think that the key when you're looking at transplant programs is you want the place with the busier volume. And then you also want to, and I'm not obviously involved currently, but you want to look at the fellowship programs within transplant and look to see what the training product actually is. So talk to your if you're interested in transplant, talk to your transplant mentors to see what they think about that institution. You cannot, I think, no matter what fellowship you're going into, you cannot put a price on talking to your mentors and getting advice from them, because one size doesn't, just like they're all different, one size doesn't fit all. And they'll also have an idea as far as, places that were good, but all of a sudden faculty are leaving and who's coming and kind of those things, and just the secular trends within the field, which can change. So for HB, they have to do 50 or more major HB cases a year. And then a subset of complex biliary cases. These are all cases that are involved resecting more than 2 segments, and then also cases that are not obviously not just doing gallbladders. And then to add the pancreas addition onto it, you have to get the HPB designation. You have to have 25 non-transplant related pancreatic procedures involved in it. And I can tell you, like from my practice, doing HB in addition to transplant is just it makes sense. It flows well because I think you utilize a lot of the same skill. You utilize a lot of the same skill set between the two. I mean, obviously, you can have debates. I think there's some things that we do well. I think transplanters do well with arterial reconstructions and portal vein reconstructions and whatnot. I think that we oftentimes where some of us fall short is maybe actually understanding the oncologic basis of the disease. I mean, and that's coming from somebody who's in the field. So individually, the fellows during their transplant fellowship, their volume requirements are 45 liver transplants, 25 multi-organ procurements, and then for the HB, a minimum of 35 HB cases, and a minimum for the hepatopancreaticobiliary, you have to have a minimum of 50 of these HPB cases divided up, amongst the hepatectomies, biliary procedures, and non-transplant pancreatic procedures. This is a picture with one of our fellows when I was at UAB, I think starting a liver transplant. So, the other part is it has to be a part of a multidisciplinary, the transplant fellowship has to function within a multidisciplinary approach with a tumor board. One of the things, like I said, is, it's not just technically doing it, it's also understanding the biologic and the oncologic reasons behind it, behind what you're doing, which again, I think was probably most people's criticisms of sometimes of the transplant pathway, but this is what's requirement. And then so focusing on the fact how HB is not just a technical skill, but it's taking care of that entire patient. And then this just shows this is relatively new, the transplant fellowship certification pathway. So you match into an abdominal transplant fellowship, you complete the fellowship requirements, you apply for and receive the certificate of competence from your fellowship director. And then you practice for a year, you submit your certificate application, and you finally sit with a high stakes exam, in which you currently only have to pass by 50%, and then you're certified with the you're certified abdominal transplant surgeon. And any questions, I'd be happy to answer later or now. Thank you.
Any questions right now, or we'll wait till the end? All right, great. So the next person I'm going to introduce, I won't make fun of my partner, is Anay Kathari. He's my junior partner at Medical College of Wisconsin, and just an incredible human and an even a more talented surgeon. He completed his fellowship in complex surgical oncology at MD Anderson. We were lucky to recruit him to MCW a little over a year and a half ago. He's going to talk a little bit about HPB careers from the CGSO pathway.
Could have made fun of me a little bit. Well deserved, probably. So excited to talk a little bit about this. Maybe I should have said this is the best way, but I just thought at least I'll talk a little bit about surgical oncology as a pathway towards a career in HPB. I kind of frame a little bit of this on my own personal experience. So there's a little bit of N of one that kind of goes into this discussion. I'll also mention that I am our associate program director for the Surg-Onc Fellowship. And so that also kind of informs a little bit of this as well, but try to think about it in a broad sense too. So just to give you all a general idea of just the pathway, and this is, I think relatively typical, you do a 5-year general surgery residency. Most CGSO or complex general surgical oncology applicants will spend 2 years during that time doing additional professional development time, typically in the research setting, whether that's basic science, translational, or other opportunities. I then did my 2-year surgical oncology fellowship at the University of Texas MD Anderson Cancer Center, and now I'm a complex GI surgical oncologist at the Medical College of Wisconsin. I thought it would be helpful just to give you a general sense of what the other fellows that graduated with me are kind of doing right now. So one is doing a practice that's HPB plus complex GI, about 50-50 between those two areas, and also does global surgery research as a major part of what he's doing in his clinical life. Another one is primarily academic affiliated community practice, very, very high volume HPB, including advanced robotics. Another one is academic surgical oncologist at a major cancer center who's sarcoma focused. Another is doing HPV complex GI, again, an academic center, regional referral center, growing programs around not just HPV, but complex GI. And then the last of the graduating fellows is at a safety net community access hospital, does the full spectrum of general surgical oncology, including HPV, but also colorectal, sarcoma, melanoma, so kind of the full spectrum. I always kind of describe my practice as a stage 4 disease practice. I do colorectal liver metastases. That's the liver part of my practice. I do peritoneal surface malignancies, and then robotic surgical oncology as well. So complex general surgical oncology is an ABS certified and an ACGME approved fellowship. So coming with that are the requirements around ensuring that there's a basic set of requirements that are met through the training process. This actually happened in June of 2012, and I think the first set of graduates was in 2014 or 2015. So, surgical oncologists have been trained for a very long time, but in terms of this kind of more formal structure, it really started just, about a decade ago or so. Yeah, this link here just lists the open recruiting fellowships for this cycle. It's about 40 or so, and that fluctuates a bit because there are some fellowships that'll take 1 fellow every other year, some that take 1 per year, others that take multiple per year. But that list is the most updated that you can see as you're kind of working your way through it. I think historically, surgical oncology has been looked at as kind of a challenging to match into specialty, and part of that is based on the match rates and the applicant pool that's applying, in that first year, about 46% of applicants did not match into a surgical oncology fellowship. That has improved with time, about a quarter or so now is the number that was stated in this paper, but actually that number is even less than that over the past 2 match cycles, in part as new programs have opened, and then also the need to kind of train general surgical oncologists that will treat in the community as well. So that is improving and changing over time, but it does still remain a competitive subspecialty. I wanted to highlight just what the minimum training requirements are. I think it's really important to look at the case numbers that are required during the fellowship to think about, what your training experience will look like in HPB specifically. So, the minimum requirements are relatively low, especially when you compare it to specialties like transplant or the formal HPB training pathway. And again, this is over 2 years. And so, the HPB numbers here, the minimum case number is 35. And then there's this additional requirement, which is multidisciplinary case numbers, which is unique to surgical oncology, where you have to do cases in some multidisciplinary setting where you have the discussion with the other potential disciplines that are involved. So that is something that I'll highlight, which I think stands out when you're thinking about training in this, is ensuring that you are actually trained in this multidisciplinary type of paradigm. This is a little small, but all the disease sites that you train in are represented on the CGSO qualifying exam. So once you've completed a CGSO, which is I still laugh every time, it's like complex and general. I don't really know why that, what seems like a contradiction, but that's actually what it is. It's complex and general, but it's a total aside. So 14% of that test, the qualifying exam is HPB, and then once you've taken the qualifying exam, there's a certifying oral exam to follow that. I wanted to point out basically 2 type of block schedules, just a very tangible and granular look at what fellows do on a day-to-day or month-to-month basis. This is at the Medical College of Wisconsin, and I'll highlight that we have a dual accredited SurgeOnc plus HPB fellowship. So graduating from our program you would be dual certified in both, which is why there's a little bit of an increased emphasis on HPB through the block schedule, but 12 of the 24 months are HPB focused. And then I'll highlight that there's actually 4 dedicated months for research. You spend time on the medical oncology services, radiation oncology services, and pathology services, each a month long, really allowing kind of depth and breadth into each of those specialties and making the network and the connections to be able to succeed in those areas in your clinical practice. This was when I was a fellow. This is actually my block schedule. So MD Anderson has the ability to get an HPB certificate, but it's an additional year. So for those that do the complex general surgical oncology fellowship, it's a 2-year program. And in this circumstance, you can actually get a fair amount of HPB dedicated time. I did 7 months of the 24 on HPB services. I was trying to find my case numbers. I couldn't remember them, but and same thing, 4 months of research, med-onc, rad-onc, pathology, again, dedicated times to be spending in these other specialties. And so I just wanted to kind of conclude with what is the phenotype of someone that's CGSO trained who also is an HPB surgeon. I think that we often will describe ourselves as cancer doctors who also do surgery, and that's part of how the training has been developed. There's advanced and focused surgical training, but the technical intraoperative aspects would be the piece that are probably, when we're talking about where there's not as much emphasis, it's probably that piece. It's more on the more broad scale piece of learning the multidisciplinary aspects of oncologic care. You get that perspective. There is dedicated time to learn and develop a research foundation and focus. There's broad exposure. So, many clinical practices will not only have HPB, but will have other things involved within them. And it's the network that you get, not just from the surgeons that you work with, but also the multidisciplinary teams, because you do spend time, rotating on their services. That's all I got. Thank you.
All right. So then we'll hear from Dr. Kimberly Washington, who needs no introduction. But Dr. Washington and I met actually at HPBA a couple years ago when we were, I think when she was a first-year fellow. or applying to fellowship actually for HPB. So she completed an HPB fellowship at Oregon Health Sciences University and is now in a hybrid practice at Texas Health Harris Methodist Hospital. And so she's going to talk with us a little bit about the HPB track and what that looks like.
So first to clarify, I absolutely do need an introduction. So I did HPB fellowship at Oregon Health and Science, and now just started in October in a hospital employed setup in Fort Worth, Texas. So just I don't have any disclosures, but obviously I welcome them. But so this gives you kind of my timeline. It's a little off compared to what most of you guys will experience, but I trained residency at University of Tennessee in Memphis, very high, like heavy trauma experience. So a lot of open surgery, like that was our thing. I did very little minimally invasive surgery in residency. Finished in 2014 and then went into private practice, general surgery in Texas. I was there for 6 years from 2014 until 2020. And then I don't know if I had a midlife crisis or what, but I went back to fellowship in HPV surgery at OHSU, which I finished. Did that through the entire pandemic, which was actually somewhat good, I think. Not having any outside things kind of pushing in on me to want to do things outside of work. And so I think that ended up being a very beneficial thing. And then currently at Texas Health. So just to give you kind of an idea about HPB fellowship, there are a couple of, it's one fellowship setup, but there are 1-year training programs, there are 2-year training programs. OHSU is a 2-year program, and so a lot of my experience and a lot of my viewpoints are from that, that experience. But the 1-year programs tend to be very, very high volume, especially pancreas. And then the 2-year programs tend to give you a little bit of a mix, I think, just from my experience. I had a liver transplant experience. Our program was set up, it's changed now, but it was set up as 1 year of transplant, 1 year of surg-onc. And so we rotated 3 months on surg-onc, 3 months on transplant, back and forth until we finished out the 2 years. And that was really helpful because obviously the liver transplant surgeons are excellent with liver cases. They're excellent with portal dissections and just getting vascular control, doing multiple, I think I did almost, well, my case volume is up here. I think I did almost 70 liver transplants in that year. And so just doing portal vein anastomoses over and over and over again was just helpful for my current practice, particularly for pancreas. We also had a fellow exchange program at OHSU, which hopefully will become something that we do a lot more in other HPV programs. At OHSU, our pancreas numbers were a little light. And so just to give us more experience with that, we exchanged with Virginia Mason in Seattle, where they have a very, very high volume pancreas experience, as well as they do a lot more benign pancreas disease, and they see a lot of bile duct injuries, which we didn't see that as much at OHSU. So I got 6 weeks up there to do a lot of crazy things, and their fellow didn't get a lot of liver experience, and they didn't have a transplant experience there. So their fellow came and swapped with me for 6 weeks of transplant. So I did 6 weeks shy of a year of liver transplant. We also, as a HPV fellowship, have a monthly grand rounds. It's a virtual 2-hour experience where we get together with all of the other HPV programs and the AST programs that have HPV track, as well as the CGSO programs that have the HPV track, with all of our attendings and some of the national leaders in the HPV world. And they have topics that we go over. And that's one way that they found to ensure that we get exposure to some things that may be less often seen in your location, but is more often seen in another location. So one thing we didn't do a ton of was chronic pancreatitis, but they do a lot of it in Indianapolis. And so they tend to kind of head that discussion because they do a ton of pancreatitis there. So it gives you that experience, and then you're getting all of the other perspectives from other attendings around the nation, US and Canada. We also have an ultrasound and ablation training. That is one thing that I think sets us apart, specifically from transplant as well as from CGSO, is that we do have a requirement of doing a certain number of ultrasounds and ablations as part of our training process, specifically for the liver, for the pancreas. And it's a requirement as part of our pathway. So they used to do this in person before the pandemic, which I've just missed that by a year, but they would go to North Carolina to Dr. Iannetti's group and do an in-person ultrasound course along with ablation course, because they do a ton of ultrasound and ablation in North Carolina at that program. And so that was one way that all the fellows would learn their techniques directly from that location, even though they weren't being trained by them. So hopefully that'll come back now that the pandemic is over. So I hope so. And then obviously early involvement in HPBA, they really push this at the beginning of fellowship, is to join a committee. And I think that that is huge, especially because you've got to get a job afterwards. And it's important to know the leaders that are part of this organization and them know your work ethic, even if they don't work with you. Because it can help you in the job hunt. And these people out here, the big names that you hear about all the time, they know where the jobs are. And so it's helpful for them to also know you. So that has been very helpful as well. So there have actually been several studies that have been published about HPV training practices, specifically oftentimes from Dr. Jay Raj's group. And so there's probably 5 of them that you can search on your own if you just want to know kind of what they found. In this particular study, they did a survey analysis of what HPV fellows had an expectation of when they went into fellowship. And interestingly enough, they expected to do about 150 to 250 cases during their fellowship. They felt that MIS in HPV was important, but none of them really felt that they would get enough training to be ready to do it on their own. And this was published several years ago. And then also related to autonomy, most of the fellows, as you can see, felt that initially the attending should be performing the case and the fellow should be assisting the case. But then there were some that expected to be able to perform the case on their own at the beginning. And I think the element of autonomy is one of the things that I have seen a lot of residents get frustrated with when it comes to going into fellowship. I'm a fellow now, I should be doing these cases myself. And honestly, one of the things I would add for my experience in HPV, especially as someone who is already in practice for 6 years, it was tough, right, to step back and be an assistant, but it was very, very important. And so just this is an add-on piece, like an extra little tidbit, just understand that that when you're going into fellowship, whichever fellowship it is, there's a lot of value in actually assisting and watching someone else do a case, especially a very complex case, before you actually do it yourself. So just want to throw that out there. This was another similar study, but looking at the other side. How did applicants for HPV or program directors for HPV surgery, how did they look at the applicants? What was the most important thing? And I think this is important for you guys, particularly the ones here who are our residents, is that, you know, they looked at the motivation, passion, and work ethic, the collegiality and professionalism, as well as the academic curiosity and productivity. Those were kind of the top 3 things, because there's no way that they can assess your technical skills. So, you know, because unless they actually worked with you at some point. And so, but these were the major things that came out of this study, just for the ones who are residents currently and are planning to go into HPV fellowship. And then this study also looks at kind of where these fellows landed. And I won't go through all these because these are too small, but we are seeing somewhat of a shift of people not so much going into academic practices when they come out of HPV fellowship, but going more towards community or hybrid models. And so that's something I think is important if you're a resident or even if you're a fellow currently applying for jobs, is that adjust your expectations somewhat. And I can only speak for HPV, I can't speak for transplant or CGSO pathways, but in an HPV pathway, adjust your expectations, because the likelihood that you will get an amazing job at Washington University and whatever is lower these days compared to maybe what it was 20 years ago. But there are excellent opportunities in hybrid models where you can get a lot of the things that you want out of an academic experience without all of the negative things that come along with the academic experience. So this is just an example of all of the HPB programs, including some of the CGSO combined programs that are out there. There's not a ton, right? So I think they have somewhere between 17 and 20 spots each year in the US and Canada. And I may be missing a couple of them. I went on the Fellowship Council website in order to see these are the ones that have spots this year, and some of them only take one every other year. So, but it's not a ton of programs, it's not a ton of options, but I can honestly say that for the places that are here where I actually know people who trained in them, they were satisfied with their training at the end. So going to my case log, because I took a screenshot before I finished fellowship. So this was maybe 3 weeks before I finished fellowship. So 663 procedures entered. That means that's when they broke down every element of the procedure. And that was out of 260 cases. So many of the cases had multiple procedures within it because I separately had to log my ultrasounds, separately log my ablations, separately log my partial hepatectomies, et cetera. So, so for about every case, I did 3 different procedures in the case. I had a total of 120 liver cases that included transplants, about 32 Whipples. I think I added a few more by the end of the year at that point. Let's see, 40 pancreas. That includes the distals, which, as you guys know, is much rarer than doing Whipples, mainly because they present metastatic often. And then there's some other things if you scroll over, but I didn't actually scroll over. So my HPV total was that I needed was 100, and I had 185. And then this breaks it down a little bit. And sorry, I know it's kind of small, but there was no way to make it bigger. Underlined up top, I had 114 biliary HPV cases, 178 liver HPV, 191 of other HPV. That includes all of my ablations and things other than your typical liver resection or pancreas resection. 41 pancreas, 58 transplants, and then there were also other things. So you can see that there were random other things. I did a couple kidney transplants in there, which I think are under the solid organ. Did a thoracic case, which I can't even remember what that was. And some endoscopies as well, whatever was necessary at the time, I was willing to do. I'd done all of these other things in my private practice. So if they needed somebody to do a hernia, I'll do it. And so, as well as some vascular as well. So it was a nice experience to get to do some of the things that I've been doing for 6 years that I was confident in that, you know, I could knock out in half an hour or an hour, but also do these very complex cases. And so that was my experience at OHSU. So I would say if you're interested in HPV fellowship, for the ones who are residents currently in the audience, choose wisely. Know that you can't rank both Surg-Onc and HPV. You can only rank one or the other. So you can interview however much you want to interview, but you can't rank both. So you will have to make a choice at that point. I'm not sure how it works with ASCS because I don't know their application cycle. But for Surg-Onc, their match day is like a week before HPV. So you can't rank both of them because you can't get out of one or the other if you match. If the volume of HPV is a determining factor, you need to know the numbers of the places where you're going to apply. And so that's something that's important to know. So if what you care about is doing more, I want to do more cases in order to be prepared, then the best way to do that is to know those numbers. And I gave you OHSU's numbers, so you got them. And then autonomy is variable, and that's not a bad thing. And it's the thing that I think is important to realize when it comes to autonomy is that you have to put yourself in the shoes of your attending, right? Which was easier for me because I'd done that already. I realized that the onus is on the attending and not on the fellow or the resident. And so understand that you will have some attendings who are a lot more comfortable with giving you that autonomy, and you will have some who are a lot less comfortable. And I dealt with both at OHSU despite my experience. And so it's one of those things that I just throw out there as an extra tidbit, like get your mind right for it. And then don't be afraid to go back to training. I know that there are some people in the audience who have been in practice already and you're considering potentially going back into training. Don't be afraid to do it. It is hard. It is a hard mental process to go back into that training experience, but it's definitely worth it if it's something you want to do. And if you apply the first time, it is not a bad thing to apply again. And I probably don't have to tell you guys this, but and that's the same thing as it turns out for jobs. If you apply for a job at a particular place and you really want to be there and they don't select you that year and 3 years later they have an opening, apply again. Okay, it's the same thing. So definitely keep your options open. And I think that is all. That's my email in case you have any questions.
All right, fantastic. So we're going to talk a little bit more about the application process and delve into some of the more critical components. Marty Russell is going to talk with us. So Marty is a surgical oncologist, HPB surgeon at Emory University, also a very good friend of mine. We've overlapped a little bit in training, but also met and really connected here at HPBA. So thanks so much, Marty.
Hey, good afternoon. So I'm Marty Russell. I'm the program director of the CGSO Fellowship at Emory and also the vice chair of the program directors committee for the SSO. And I do have some slides. How many of you guys in here are medical students? Are there any medical students in the room? Couple. And the rest of you guys are residents? Yeah, okay. All right. So I'm going to talk about key components of the application. I have no disclosures. So nearly 80% of general surgery residents pursue additional training after their residency. And there's variable reasons. Some will have an interest in a particular specialty. Some want to improve their skills, get some more numbers under their belt, improve their confidence and experience. Others want to narrow their scope of practice so they can select which cases to operate on. And sometimes they just want to improve their marketability in the job search. So multiple different reasons. Surgical fellowships, however, are often competitive to get into. When you look right here in this study, which was published in 2020, abdominal transplant surgery and complex general surgical oncology both have match rates of 61 and 64%. So a lot of people are not getting into the program. We've already talked about the 3 different ways that you can get into HPB. I'm going to go through some of the publications that have been done for each. So first, we're going to talk about CGSO. This slide you've seen already. The number of programs that between 2014 and 2021 increased during this study period from 23 to 34, and now they're actually up to 38. And importantly, what you see up there in the circled numbers are the percent of applicants that go unmatched. And so the good news is that the number of unmatched applicants is actually going down. And this is true both for US graduates as well as graduates who are applying from foreign medical schools. This gives you an idea of where people are matching. So in the red here, you see the number of patients, the percent of people who are unmatched. And you can see that in the blue lines, this is the people that are able to match into their first choice program. And then it teeters back and forth a little bit between whether people are matching into their second, third, or fourth or greater in the purple here. So what are the program directors looking for? This survey was sent out in 2018 to, at the time, the 30 different CGSO groups, and 29 of them responded. The mean number of applications that were received per program was 73, and the mean number of applications per position was 49. The average number of interviews granted was 26, and so that comes out to a 37% mean interview rate. So just because you're applying doesn't necessarily mean you're going to get an interview. Factors that influence the decision of the program directors to invite and interview candidates. So this gives you just 3 examples. So 72% of programs have a prerequisite for ABSITE score that's used in interview selection. And you can see on the right there, it varies from 25th to from 10 to 25th percentile all the way up to 90th percentile, with the majority of programs requiring 50 to 75th percentile. 82% of programs have a prerequisite for quantity of published manuscripts that are used for the interview selection. And the number that's most commonly used is 5 for that. And then 66% of programs have a prerequisite for first authorship manuscripts in order to be selected to interview. Those numbers tend to be lower, and the majority of the programs said that they just had to see one of those. When we look at other factors that the CGSO program directors are looking into for inviting people to interview, if you spend time either on a clinical rotation or on a research experience, you're more likely to get an interview. If you have a dual degree, you're also more likely to get an interview. And for CGSO, unfortunately, if you've applied once and not been accepted, then you're a little less likely to get an interview. Consideration of ranking after interview. So what's important to us after we meet you? So the first 3 that are most important: teamwork ability, interpersonal and communication skills, interaction with other applicants, and non-physician staff. So remember that, surgical oncology is a team sport. So we want to see your ability to work in a team. Communication skills, again, have to be very good for this job. And finally, you have to interact well with the other applicants and not be a jerk to any other people. So just make sure you're nice. Other things that are important: ethical decision-making, operative skills. Again, this shows up on multiple different interviews. As a program director, I'm not really sure how you assess somebody's operative skills other than from the letters of recommendation, which is the next thing on the list. Medical decision-making and interest in the CGSO program. So don't apply to programs or accept an interview for programs you're not really interested in, because it comes through pretty clear on the interview. And then you can see the other things that are important. When we look at the scale of importance for these 5 factors only, so interview, publications, letters of recommendation, personal phone call, and ABSITE, what you see is obviously the interview is the most important. Publication research came in second. And down at the bottom is the ABSITE scores. But remember that in general, most programs have benchmarks already for what they're willing to accept. And so once you meet that benchmark, you're okay. So this was a study done at a little program in Houston and published back in 2019, looking at the effect of the board certification. So we already talked about how in 2012, it became an ACGME accredited program. And MD Anderson wanted to look at the difference in applicants. So this breaks it down male to female. Still about 2/3 of the applicants are males, with a little jockeying back and forth depending on what year. The average age for the MD Anderson applicants was 33. The majority, 66%, were U.S. citizens, and the majority of people trained in the United States was 63% of them. The majority of these applicants were university-based programs. Most everyone had done had peer-reviewed publications and first authorship. When you look at the pre-ABS versus the post-ABS applicants, the differences is that there was an increasing number of people that did dedicated research outside of residency. There was also an increasing percentage of applicants that had peer-reviewed publications and first author publications. And then down at towards the bottom, it went from 13 to 20% of applicants actually had a year or more between residency and the completion and the fellowship application. And in that same vein, 12% of applicants were in practice at the time of the application. When we look at the predictive factors for those people that actually matched at Anderson, the things that were most important and most associated with match were a U.S. medical school, AOA distinction, dual degrees, and if you had done a rotation at MD Anderson. So moving into HPB fellowships, which we heard a lot about already. So these applicants tend to look a little bit different. This was a study published by Dr. Baker in 2016. 37% of the applicants were from United States medical schools and another 22% from Canada. 62% of the applicants had completed residency in the United States. ABSITE scores were really high for this group. So less than 10% of people had a less than 50% ABSITE score. So 90+% of these applicants had greater than 50% on their ABSITE scores. A slightly lower percentage of patients had done research outside of dedicated research during residency. But the majority of the applicants had held some sort of leadership role, either administrative chief or on some hospital committee. This looks at who was, how many of the fellowship programs were the applicants applying to. The majority applied to 11 to 15, and the majority of applicants were offered interviews. And people ended up interviewing a third at 11 to 15, a third at 6 to 10, and 40% interviewed only at 1 to 5 programs. Again, looking at what factors are important from a program director's standpoint, interpersonal skills is the number one, followed by operative skills, again, usually judged, unless you do a rotation, they're usually judged through your letters of recommendation, and perceived fund of knowledge as well as communication. So you can see some overlapping themes here. This is a little difficult to read, but the top characteristics that were associated with matching were the strength of the applicant's interview, the strength of their CV, letters of recommendations were really important, as was completing residency in the US or Canada, as well. The type of residency was important, and some research experience. I just want to point out here again, ABSITE and leadership are further down, but again, this was a very highly qualified group, and so they were already meeting those standards, so that it became not an issue for many of the applicants. And then when you ask the program directors what was the most important, by far you can see of these three factors, the interview was considered very important or extremely important, followed closely by CV and letters of recommendation. For transplant surgery, there's not very much data on what the program directors are looking for, but I did want to show you this that shows you the available positions over the last 15 years has increased from 60 to 76, and the positions being filled is about between 60 and 70%. Again, for transplant surgery applicants, there's a lot more foreign graduates than US medical grads, but it goes back and forth a little bit. So how do you get the job? First of all, you have to get the interview. So this is, I think, the crux. So ABSITE scores. So gone are the days when I was applying many, many moons ago, where the only person that asked me about my ABSITE scores was Dr. Coit at Memorial Sloan Kettering, and no one else from the other 12 programs I interviewed at wanted to know about that. So you have to do well on your ABSITE. So put in the work, do your QBank or whatever you guys are using, go through your programs, remediations to make your ABSITE score so that it's not, it doesn't hinder you. You got to publish, and not everyone takes off time during their residency to do dedicated research time. You can do it while you're in residency, but you need some publications as well as first author publication. If you're really interested in a place, try to do a rotation there, either a clinical rotation or research experience there. That seems to be pretty important. Leadership and teamwork demonstration are also important for everyone. And then letters of recommendation. I often get asked if it's more important to have the chair write a letter or somebody who actually knows you. And I would say probably a mix of both. So it's nice to get letters from the people that do surgical oncology or who do HPB. It's nice to get those letters, but also nice to get a letter from somebody who actually knows you. And a strong letter from somebody who knows you is better than a mediocre letter from somebody who doesn't. Interview by far is the most critical step in getting the job. And luckily, Dr. Cleary is going to address all of that in just a moment. Congratulations to all of you guys for being here. A lot of you are presenting, so you're already headed in the right direction with research and with publications and with getting to know people. Do reach out to us. We're happy to meet you. My email address is here. If I can do anything for you or offer you any advice, please feel free to reach out.
That was great. So I think Dr. Cleary is going to come and talk with us a little bit about some of the most effective skills that you can basically utilize in your interview. He also needs no introduction, but we're looking forward to his presidency as well of the HPBA.
Thank you so much. Thanks, Clossie. And again, thank you everybody for having me speak today. So at the risk of, I have no really relevant disclosures, but actually, in terms of industry funding or anything else like that, but I will disclose that, and this ages me a little bit, that my residency or my fellowship interview consisted of having a beer with Paul Gregg at the Madison Avenue pub and that I had told him a long time that I would never buy loops until I had secured a fellowship. And he told, he basically said at the end of this beer that I should buy some loops. And so that was the process that I went through. However, after being a fellowship director for almost 12 years and now a chair of a division, I've been on both sides of these equations, both interviewing fellows as well as interviewing faculty candidates. And I was talking to Dr. Clark and said, do you want me to cover faculty or fellowships? We're going to do a bit of both, and I'm going to go back and forth because these are kind of things that I wish someone had told me early on in my career, because everybody kind of just assumed that I would know these things, but no one ever did. So let's talk about fellowship interviews. So fellowship interviews, and thank you, Dr. Russell, for that amazing thing set up for this. It is a relatively standardized format. Most programs will have standardized questions. They'll want to evaluate candidates on, on similar metrics. Now we're in a world where most of them are being done virtually, and so I think that's just important to it's a different dynamic. It's different in the fact that I think it's a hindrance because you actually don't get to see the institution and you don't get a vibe for the place unless you've taken the opportunity to take time out of your training to go visit that institution. I think we're all trying to navigate these no stakes visits, and I think if you guys are confused about them, so are we. So we're trying to figure out how these are going to work, but really to say that there is a lot of, understanding that the city that you're going to go to, understand the institution that you're going to go to. And these are very important, not just in terms of evaluating fellowships, but in terms of life experience, because for the most part, you may have seen one or two institutions through your medical school and residency training. It's good to see other institutions and how they function and structure. There will be different structures. So, and again, just a slightly different dynamic, whether you're interviewing one-on-one, two-on-one, three-on-one, or a whole group interview. One of the things that people find is that whole group interviews can be a little bit intimidating, but it's no different in terms of it's still just you. But just understand that it's not meant to be intimidating. It's more about efficiency from the program's perspective, but expect that, each of the members of the panel will probably ask you a question. But I think you guys have all been, many of you have been through residency interviews. Many of you have been through medical school interviews. And again, I don't know if there are any undergraduates here, but you're starting to get a little bit more experienced about how to actually conduct an interview. And really, I think the thing that candidates underestimate is that this is a two-way interview. Yes, they are interviewing you to see if you are a good candidate for their program, but as much of it, it is as much you interviewing them to try and see if this is the right program for you. Okay, I think that that it's a very misunderstood power imbalance. I think there's less of a power imbalance than people realize, because quite frankly, the programs all want the best candidates. My objective as a fellowship director is to have everybody that we interview rank us number one, because then we get our best choice. We want to impress you as much as you want to impress us. Now, here's the part that nobody told me about, and that is when you go to interview for a job. And this is, again, you sense a very huge power imbalance. Many things have changed with COVID, and we're still kind of coming out of that, but many faculty interviews will be a two-stage process. There are often two interviews involved. Some of them may be virtual. At least the first one may be virtual. You definitely should not accept a job without being on site, would be my personal opinion. The first interview someone described to me is the getting to know you interview. They're going to talk to you about your skills, about your goals, about your training, and about your interests. And they want to know if you fit what they are looking for. They might ask you to give a talk, a presentation at rounds, just to kind of get an idea of, again, your research interests or clinical interests or expertise. They'll want to know, as has been mentioned already today, about what skills you might be bringing to the institution, how much you be adding to the group. So this is very much them interviewing you. It's not a time to talk about money. And it's not a time to talk about RVUs and all of those kind of things. Those will be for interview number 2, because interview number 2 is very much you interviewing them. Are you going to be a fit for this institution? Are you going to be a fit for this group? It generally should include an invitation for your partner or spouse. They should give you time to get to know the city or the town or the environment they are. Good institutions will make sure that your partner is as welcomed as you are. And that is the second interview where there's time to talk about the details of the position, what kind of time commitments, what are the productivity expectations, what are the salary expectations and funding expectations. So that's kind of where they are. Generally, many programs may interview 4 or 5 or 6 people for interview number 1. And then interview number 2 might be at least one, their top candidate, maybe 2 candidates. The other thing that I think that was very valuable advice is that if you're not sure about an institution, it's very okay to go for interview number 1. This is the get to know you interview. But if you're going to go for interview number 2, if you're going to ask an institution to pay for your partner or spouse or family members to come, if you're going to pay, they're going to pay for a real estate agent to take your partner around town, or they're going to take you to see schools, you should be pretty sure that this is you're very interested in this position, because again, this is something where the level of investment from the institution into that interview goes up significantly. So if you and your family and whoever is important in these decisions in your life decide, you know what, there's no way under in this current context, we'll go to institution A. Just say, if they invite you back for an interview number 2, say, thank you very much. I really appreciate the opportunity to interview, but we'll be looking for other opportunities. So if you go for interview number 2, you should really be interested in that. One of the things that obviously this is, yeah, okay. Fail, like very well done, like everybody says that, but I think that one of the things that separates people in interviews, and one of the things I've noticed, is how prepared they are going into that interview. Okay, you've all done interviews, and now I think that for the most part, everyone expects there's going to be different levels of anxiety and discomfort and shyness and those sort of things. By this stage of career, hopefully you've got coping strategies for those. But it's the prep, and most people, if they're effective interviewers, will be able to separate just someone, different personality types and different comfort levels of the interview situation. But the preparation for an interview, I think, is what really often separates people. So get to know the program that you're applying to. In the pre-internet era, this was extremely, extremely difficult, but now it's incredibly easy. You should be Googling, searching everything you can know about that division, about that department, about that institution. What are their strengths? What are their weaknesses? What are they known for? What's the environment? So is this private practice? Is this academic? Is this mixed? What is their practice like? What are their training programs? Is this a place where you're going to have residents or fellows? Kind of not having those basics going into a place sort of makes people wonder how interested you are in their institution. What can you bring to the group? Do they have practice gaps that you're hoping to fill? Another important thing is, it's amazing. Know what's in your CV and know what's in your personal statements. It's amazing how sometimes we've asked people in interviews to clarify or expand on something that's in their CV and they draw a blank. And I get that sometimes that's nerves, but hopefully there's a lot on your CV. But be prepared to talk about papers that you've authored. Be prepared to talk about experiences. The classic is someone's written something in their personal statement about a patient experience they have. You bring up that patient and they're drawing a blank. So remember, they know as much about you as you've provided to them, but make sure that you know the information that you've provided to them. And know, again, this is a little bit for both fellowship and faculty. Know what the deal breakers are. What's going to be a deal breaker for you? What's going to be a deal breaker for your family and anybody who may be coming with you to this opportunity? Get the interview itinerary. Know exactly who you're interviewing with. One of the things that I usually do on the flight to an interview is I have some of the representative papers that those people have published, because if an interview is not going well, or you're wondering what kind of questions ask, if you say, hey, you know what, I was reading your paper on this, can you tell me a little bit more about that? that shows that you've got a level of interest in that person. And, you know, listen, who doesn't like talking about the papers that they've written, right? I mean, you're just playing into their ego, right? So do your research, look at their bios online, look at their papers, look at their research and academic interests, so that, again, if the interview kind of stalls, you can actually spur the interview by asking them a little bit about them. This can occur sometimes with faculty interviews. Notice who, you know, again, you've done your research, you know who's in the department, you know who's in the division. Who's not on your itinerary and why? So is somebody out of town? Is there someone in the group who, you know, really isn't into hiring another person and they don't want to expose you to that person because, you know, you might get a negative vibe from them? That is something that I learned the hard way interviewing at an institution. What are the pertinent negatives? Who's not on there and who's not on board maybe with you coming on board? Again, from personal experience, ask for a map. Don't try the night before to map out where you're going. It is really adds incredible amount of stress to your day if you don't know where you're going, or you don't have a map, or you get lost and you're subsequently late for your next interview. Simple thing, but I got to tell you, if you don't do it, you're like standing in the middle of some hospital you have no idea with, trying to find a staff person who knows where Dr. So-and-so's office is, and often they don't know. So I think that is kind of, oh, there should have been more slides there. I think in terms of questions, I think that, you know, obviously, I think Dr. Russell alluded to it. The one question type that I see that people are not prepared for are the behavioral and emotional intelligence questions. And those have become basically standard. So be prepared for them. No, people are going to ask you, tell me about a time when you struggled. Tell me about a time when you had to resolve conflict. Tell me about how you interact with people, because as you saw, how you interact with a team is going to be one of the most important things that that people want to know about in terms of fit. Other piece of advice that we're supposed on the missing slide were, you know, one of the things that I found is I was afraid to ask certain questions because, again, they may have been on that deal breaker list. Ask that question. Okay. No one should ever be afraid of asking a question. No one should ever say that, oh, we found it. That there's that, that you wanted, that you want an answer to the question. No one should be, there should be no, other than, you know, clearly off base or personal questions, no one should be offended by a legitimate question. You know, so again, basics, be punctual, be attentive, if in doubt, overdress. But that doesn't mean pull out the tux or the, and you know what, life happens. Flights get delayed, you get lost. If you're like me in that hospital, you couldn't find Dr. So-and-so's office, just call somebody. Usually there should be a contact number. Don't sort of suffer in silence. Just let them know, like, these are people you're talking to. They're not going to judge you because you get lost. Listen closely to the questions. Make sure that you're answering the question that you're being asked, not the question that you thought you heard. Have a plan. And what I mean by that is people want to know about your goals. People want to know about what you want to do in the future. And be very specific about it. Be very concrete. I can't tell you how many people I've talked to over the years who are going to be, oh, I want to be that translational scientist person. I'm going to, you know, collaborate with basic science and provide tissue samples. That's a very, you know, from a chair perspective, that's a very sort of amorphous answer. Tell us what you're interested in. What type of diseases are you interested in? If you want to be that translational science person, how are you going to provide more value than just providing tissue samples? Because quite frankly, the institution's probably already doing that. Ask questions, be specific, be relevant, ask for explanations. There's always going to be a time to ask questions at the end of an interview, and it's good to be prepared. Even if you're stuck and they've answered every question, ask for an explanation or an expansion on something that's very important to you. Okay. So there's a balance. Be confident, be humble, assertive but respectful, ambitious, but make sure they know you're a team player. Be innovative, but cautious and safe. Final things and final thoughts. Everybody has an administrative assistant, a coordinator, or support staff that they like very, very much. Be polite to them. I cannot tell you how many times we've had fellowship candidates come through where our educational coordinator said, yeah, that person was really rude on the phone. And that people think that we don't hear those things. We absolutely hear those things. I have given gifts to coordinators who have coordinated my interviews, and I think it did well. Be careful at social events and dinners. There's usually these things. It's a very nice situation to relax and talk to people. It is still part of the interview process. Do not think anything different. If you're not sure if you should ask a question, I think I said this, ask it. And then try and understand and narrow the power and information gap through the interview. So thank you again very much for the opportunity. I hope that was somewhat helpful. And again, I'm always happy to talk about these things. Thanks again.
All right, great. So we're going to invite you guys to come up to the podium, microphones, I'm sorry, and ask any questions. While you're thinking about them, I'm going to ask a couple questions of the panels, but I really want to make sure that you guys get the information that you need before you go. So I'm going to probably ask this of maybe Marty and Anai, program directors in the room. Any bits of advice for virtual interview platforms? So I interviewed in person, and so I think it's really changed the way we interview candidates, as Dr. Cleary mentioned. Any like do's and don'ts, things that I think people need to be a little bit more aware of on the virtual platform that you can think of?
I can start. I think it's a really important and challenging thing. I think some of the same rules and overviews still apply. You know, I think that how you present yourself is really important. I know that there's a lot of attention in like curating the backgrounds and making. I actually do think that there's value in making sure that, you know, the presentation that you're making of yourself virtually would be similar to, you know, what you'd want to be able to convey when you're in person with someone. And then you know, I think that you can, the hard part that sometimes is lost during the virtual interviews is trying to have a dialogue and a conversation. But if you're able to enter into that, even in that circumstance, I think that that's important. So trying to replicate as much of the in-person interaction as you can, even in the virtual environment. I think that that's a helpful piece to do. It'll be interesting to see how that plays out moving forward, you know, in terms of virtual interviews going forward. And I think that there's discussion about that in the longer term too.
Yeah, I would say, you know, we're a very conservative bunch, so wear a suit. Your background should be clean. You should not have your pets running around. We love pets, but probably not during your interview. It's distracting to you guys more than anything. And if something happens, it's going to actually jitter you instead of us. And so you want to be at the top of your game when you're interviewing. But, you know, smile, have fun, enjoy, ask the questions that you want to know. Like Dr. Cleary said, it's your interview. So.
Everyone's being shy. I have a question, but I've been through a lot of virtual interviews, and I think what's really good practice is making sure the background is right. It's at eye level. So I actually practiced a couple of times with my wife, just making sure that everything looked right. She was on the, you know, wherever she was at work, and we just did it just to make sure things look good, because the virtual interview is awkward and very different. So you have to practice. I have a question actually for whoever's here, but we've hired a lot of people as well, and thoughts, you guys, I don't think you guys talked about it, about the interview process, but what about social media and your profiles? I know that in hiring people, we have checked, and this is more on the faculty side. I don't know what we do for fellows, but we've checked everyone's social media stuff. So I guess I would say be careful, but interested in thoughts and stuff that's out there, Calicia and everyone else, but.
Yeah, I mean, listen, absolutely. I think that you have to be very cognizant of what you've put out there on social media. Because one of the things, for instance, when you're hired on faculty, there will be trainees who will go through your social media profile. And if there's something controversial, that could create a problem in your career. So, you know, I don't think at the residency or fellowship level that there's a lot of that, but there are maybe some programs that do that. But just be aware. And listen, we all were 16 once, we all were 17 once, and so there may be, you know, some things, but be prepared to answer for it. So I think one of the things is that everyone wants to avoid the weakness in their application, right? If you had an AbSite year that went terribly, I'm always more impressed by a candidate who will dress it up front and say, listen, my PGY 2 year, it was a disaster and I got a bad score. Or I know I don't have a lot of research papers, but here's why and here's what I would like to do about it. Or, take those, there's the natural tendency to avoid the negatives, but I'd say be prepared for them. Know, again, this is why things like this are so important. Know where your strong points are, but also know where your weaknesses are and be prepared to explain them. You don't need to defend them. Everybody's got weaknesses, but just be prepared for them. And if there's something, on social media, listen, just unless you've espoused, to very, extreme ideologies, that's okay. But be prepared to acknowledge it and address it. That would be what I would say. I don't know about anybody else.
Yeah, I completely agree with that. The other thing I would say for the virtual format that I think we've encountered a couple of times is just trying to be in a place where you can have reliable internet access. And I know it's a little bit difficult because a lot of times you're not going to interview necessarily at work, but there are times where, if your signal at home is not the greatest, then it may be the best option would be to interview at work. And I think we all understand that these things are happening now. And like, I've certainly actually given my office to a couple residents for them to have interviews for the day if they've needed it. So even if you don't have your own space at work that's going to be quiet and closed, I think all of your programs will be, I think, more than eager to help you, to work with you to help make sure that you have the appropriate space to interview so that you're not distracted and that the chances of, being like, cut off during the middle of your interview, I think is a little bit less. If that happens though, I think you should not panic. It's always good to have the contact information for the person that's coordinating your interviews that day so that you can communicate in real time. And then again, try to have a backup plan for anything from power outages to, loss of internet signal as much as possible.
I'd say as much as possible. I know it's old fashioned, but be on a landline rather than Wi-Fi.
Oh, wow. Is that even a thing? Oh my gosh.
They don't have,
What?
You put in the back of your computer? No, but
you have a
Like an
plug?
email? Oh my
Yeah.
God. Wow. I've like not heard of that one. All right. Yeah. I don't think we,
you're like a desktop computer, a hospital desktop computer.
oh, yeah, if possible.
Not on your phone, probably.
Yeah,
Importantly, not on
definitely
your
not
phone.
on your phone. But the phone can sometimes be a good backup if, for example, something happened with your computer. Like, I think one person's Ethernet went out. They had a power outage in her entire building, and she was able to hop on her cell phone and get connected again. Thank you notes and letters. Any tips and tricks for that, and how important are they? Anyone want to take that?
I was born and raised in the South, so thank you letters. I like to get them. Does it make you go from, number 50 to number 1? No. But I don't know. I think it's a nice gesture. Do I count off if you don't give them? Don't send me a thank you note? No. But I don't know. It's a nice gesture if you have time.
I think it's something that just shows some interest. I mean, when I was fellowship director, if I got a thank you letter or a follow-up email with like a thoughtful question in it, then it definitely makes you, think that person is more interested. And, you spend a little bit extra time reaching out to them. The same thing I think with now I interview for residents, and, if I send an email back after the application, they send a thank you letter, you send them back a question, or they send and ask a real question. It's like, it's something that we definitely do consider. Because again, like Dr. Clary said, we all like talking about ourselves. So
It's very true. A question from the floor.
Hi, so my question is, the question that we get asked of, do you have a job, or what's your job plans? I guess it's either, I would really like to work where I'm applying for fellowship versus, I have a job backed from where I'm coming from. Is there a preference, or is there does that vary by site, or what's the best approach to that?
My experience, I don't know what others is that I don't think that that's all that relevant, that important. I think when people ask you about, your plans, they want to know kind of in a general sense, like, I want to be in academic practice, I want to be in community practice, I want to, run a lab, I want to run a translational science program, I want to run, an evidence, not so much a location, because unfortunately, the reality is that until you've signed papers, there lots of people have indications that there may be a position for them somewhere, but as my mentor used to say, with that and a bus ticket, you can get on a bus. But I don't think that I think that people want to. The other thing too is that if you say, "Hey, listen, here's who I want to be," and if that can be here, great. But if it's somewhere else, then fine. But to say I want to, my goal is to work at WashU, then I say, okay, well, that's great, but what if WashU, wants something that you're not? What if they want a peritoneal malignancy person who runs a PDX lab? And you're like, well, that's not me. So I think when people ask that question, they're looking more for, in the ideal situation, if you could have everything you wanted, what would your ideal job look like, regardless of, and you don't need to attach names or locations to that.
Hi, everyone. My name is Misha Armstrong. I'm a general surgery resident at New York Presbyterian Cornell. And I just have a couple questions, actually. Coming down the pipeline, have you guys heard about going back to in-person interviews? I know some surgical subspecialties have started to do that. Is that going to be in the future for CGSO? And then my second question is, what is the importance of geographical ties? I feel like when I interviewed for surgical residency, that came up a lot. There's a lot fewer programs in terms of CGSO. Does that become relevant or more important again?
So that's actually on the agenda for the CGSO meeting in Boston in a couple of weeks, is to discuss virtual versus in person, and whether we allow programs to do hybrid, and unfortunately, hybrid, I think, is going to be really challenging, because if somebody's in front of me, that's obviously going to be almost certainly a better interview, because instead of virtual. So we're actually discussing that in a couple of weeks. So we haven't made a decision for the next application cycle, but some of the programs have gone, smaller programs especially, have gone back to in-person.
And then geographical ties.
Yeah, geographical ties. I don't know that it's super important. I will tell you, if somebody has done their entire training on the West Coast, the likelihood of them coming to Atlanta is almost none, especially in the virtual day and age, right? Like I came to Emory and fell in love with Emory at the an in-person visit. So I think that's a little bit different. But I don't think people are coming from the West Coast who've lived there the entire life to come to the East Coast. We get a lot of people that bounce back and forth from coast to coast, and they oftentimes will make a different selection. But it's not a reason that I won't not interview somebody just because don't have ties to the Southeast. But I do think that when it comes down to ranking, and it may be something that I ask you at your interview, like, are you really going to leave California?
Yeah, I think we focus on it a little bit less, honestly. I think we understand that, there is a finite number of programs, and I think people are applying broadly. Certainly that's where your thank you notes can really convey interest. So certainly, especially if you've trained in one area more exclusively and you want to, ensure that you have conveyed that you're genuinely interested in the program and you'd be interested in moving, then I think you should try to ensure that you state that clearly in your communications.
I never thought about it that way, but I guess that's true. And I did them everywhere for residency, everywhere for fellowship. What I learned after residency is that and I had stamps and I dropped them in the mailbox. So they were literally gone. When I walked out of that city, I was done. And I can move on to the next thing. So I wouldn't remember. And I was already there. I could verify what address I needed to send it to. I did that on the way to the airport every city that I left. So
I think handwritten versus emails don't really quite matter. I think at this point, whatever is easiest. I think if you're gonna do email outside of business hours, I usually recommend that you use the sort of delayed delivery for like a business hour, just so to make sure that one, it doesn't get missed, and then also that they don't think that you don't sleep.
Hi, everyone. My name is Jonas Santol. I'm from Austria. And my question to the whole panel would be, as a non-US citizen, how can I overcome that disadvantage? And maybe more specifically, how can I, for example, tweak my CV? How can I make the residency that we have in Austria more translatable, for example?
So, having recently hired an Austrian surgeon who matched to our fellowship. So the first thing is that the criteria to be considered for a fellow should be on the Fellowship Council website. Not all fellowships will require an ABS certified residency program. Or they say ABS or equivalent and others. So those criteria should be there. And then, for fellowship accredited programs and for CGSO, we have a match process. So it really is about putting your application in the match process, and that'll get your CV to every program director, to every program that you apply to. And there are some programs both in all three streams that have a very strong track record of training, not only American, but Canadian and international graduates.
I also think that opportunities here in meetings is actually something that you should take advantage of. Making connections at these professional society meetings is really critical. It takes it away from you being, something on social media or just on a piece of paper. And I think the more you connect with people and individuals that potentially would be interacting with you or interviewing with you the process, I think it really brings, especially in this virtual interview phase that we're in, it brings you a little bit closer to, I think, your destination and to the people that you're hoping to impress. Any other?
Yeah, I'll just kind of expand upon that. I mean, I think it's really helpful to identify people that may have already walked that walk previously, and talk to them and ask, how did they overcome some of the barriers that you perceive, or maybe they end up not being barriers. And I think even broadly for those that are setting out in any of these specialties or fellowships, same thing. And to go back to what we said a couple of times, I mean, people do like talking about themselves and the stuff that they've done to get to where they are. And it's a fun conversation to have, to say, well, how did you do this? And try to either emulate it or modify it to your own personal circumstance.
All right.
Thank you very much.
So I'm going to have Margie, if you can, Margie, maybe meet me in front. We're going to sort of talk over the process. And did you want to ask the question? Please feel free.
Hi there. Thank you. My name is Anna Accentio. I'm a third-year surgery resident at Ascension St. Agnes in Baltimore. I had two questions. The first one is, we already mentioned the thank you letters. What are your thoughts on letters of intent prior to, once the application is submitted, but prior to maybe the interview itself, letter of interest? And the other question is, how beneficial, which I'm sure it is, but in your experience, is having an elective in a program that is yours, and having residents rotate through, and how, if you do an elective in the program, what can you do to stand out other than be yourself? Thank you.
I feel like I'm answering 75% of the questions. I'll actually going to defer the letter of intent question, because I think I'd be interested in what some of the other panelists are. I think if you can do an elective that is an automatic leg up. It's very difficult to do in some residency programs. It's also very difficult to visit in some institutions. But, this is a process where, in our fellowship, we're reviewing 200 applications and looking at 200 CVs, and it's difficult so what you do is, if you know them and you've made that connection, it automatically, gets your CV. Oh, I'm now looking at, at this person's CV. So it makes it a little better. Having, if there's a track record of your institution with that the fellowship institution, that helps all of these things because there's a known component to things, but that's not something you can control. But in terms of, when you go to an elective, just be yourself. Don't think about trying to be better than the residents that are there or be better than, the other person, who's also applying to that fellowship program. That generally becomes easy to spot. Just be yourself. And that's all I can say.
Oh, sorry. I mean, I think that the letter of intent, it doesn't hurt, but I think like I can think back to I've had for other positions, I've had faculty offer like they'll, faculty as you're close to your mentor, where do you want to go? And then like, okay, well, they're for your number one, they're not going to do it for every program, but for your number one, they'll call because they usually know somebody or write a letter for you. And I think that is probably very meaningful. But
Yeah, I would agree. Not pre interview, but if you find, once you're through the interview process and you want to have, you decide that, that you want to rank program ABC, it's not unreasonable to ask somebody to contact that program. And it doesn't have to be the program director. It can be, somebody who works there because they all are going to communicate with the program director. But if you're really interested, it helps to have that person reach out. As far as away rotations, I think that they can be very helpful if you come from a program that doesn't have a strong surgical oncology presence. And so that's something to think about. There are programs, and Dr. Clark and I were talking about maybe arranging something through HPBA where you guys can go and find out where those opportunities are for research or for away rotations. Might be something that we put for the next year on the DEI committee. It offers you a little bit of leg up, but when you go there, teamwork I can't stress how important teamwork is. So, don't be mean. You gotta work within the team. You gotta respect everyone on the team, from the med students to the APPs, to the chief residents, to the attendings. Don't just try to kiss up to the attendings, because I will tell you that it will become very obvious.
We all talk to our APPs.
Yeah.
Thank you very much.
All right, so we're going to break into the small group component, and we're going to actually switch things up a little bit because I think because of concurrent programming, a lot of people that signed up weren't able to make it during the session. Margie's going to announce we're going to have 6 basic tables, which will have 2 faculty members each, and we will basically have you gravitate to one of those tables and then ask whatever questions you want. If there's anything sensitive or something that you didn't want to necessarily bring up at the mic, feel free to do that. But again, just make sure that you leave here making sure that you have the answer to all the questions that you possibly could have, and maybe even some contact information for people that you want to follow up with later date. So Margie's going to announce the pairings, and then we'll head over to the tables.
And if we have 2 easels set up in back, they're both the same and sorted alphabetically by your last name. So just take a walk back to the easels, find your name, then find your group number, and then table number 1, starting over here, and you'll find your number, and then that's how we'll group. If you submitted a CV ahead of time, we do have them printed and it'll be on your table.
I'm here to make sure about yourself.
So Margie's gonna announce all the faculty pairings now, because we'll probably combine some of the tables together.
Yeah, well, I had to do a 7 a.m. session, and then yesterday there was the run, and I ran early. So I could be on the podium, but I was just like dragging. Good. I can get to bed as early as I wanted to. So. I know, exactly. But
We're gonna see tuxedos or sequins, because that was gonna be personal.
I know. I was like, oh, how do I go there and not offend somebody? But you dress like Dr. Russell was.
Then that's a problem.
Anyways.
Probably would not have been appropriate for the banquet.
100%. 100%. Just, it actually tells me that you went somewhere really, really nice. Of course, I was like the slump. So there you go. Just complimented.
Yeah, the feeling.
Yeah, exactly. So hello. Great.
Right here.
Yeah.
Okay.
Okay.
Hey.
I don't know where I am. You have a table?
I have I'm supposed to be a safety suit, but I can't find it.
Making sure that we get.
I
I don't think I was.